Now I have a Dr. Vijay Agrawal, who is a good friend of mine, very senior physician. He is the president of Consortium of Accredited Healthcare Organization, because every country, every hospital in India is not yet accredited, and most of them are non-accredited. So he is having a prestigious organization he is heading. He is in fact a founder of that organization. So the advisor of a Max Healthcare group of a hospital and quality and excellence, and advisor to Global Association of Physicians. He is a person of a great virtue. So I thought, when all this you want to bring it to India, Swedish company may like to know how India setup is there, so that they know what are the things they can bring it, because there are many issues. So I thought he's the best person heading those hospitals, and I now request Dr. Vijay Agrawal to moderate the whole session, and in the last I will again come to conclude and thank, etc. That means there would be, he will be sensitizing, then there are two speakers who will be coming from who is speaking from Sweden. There will be some question answers from both the sides, from the viewers, and ultimately this is not the end. This is the first of a series. Probably based on the demand, we will have number of such series of webinars, so that some of them who are coming to India, maybe for a conference on 5th, 6th October or later, they are well versed what India is and how Sweden can work. Over to Dr. Vijay.
Good afternoon, friends from India, and good morning to friends from Sweden. First of all, thank you very much, Dr. V.K. Singh, for giving me this opportunity to do this interaction on behalf of myself and CAHO, which is the Consortium of Accredited Healthcare Organizations. So thank you very much. I think what I would like to first of all point out that a perfect healthcare model has eluded most countries, including the developed ones. India, which is more of a continent rather than a country, has its own unique challenges. However, we have a lot to learn from developed nations like Sweden. The caveat is that these people from the developed country need to know that India is got the second largest population. We are the 7th largest country in the world. We have at the moment 50% people who are below 25 years of age, and still we have a good number of people who are now aging, and significant number of people who are now coming into the geriatric age group also. We have 780 dialects spoken, 86 scripts are being used, and still we have the second largest pool of scientists and engineers. We have a huge amount of tele-density. We have surpassed most countries in the use of smartphones. We have good amount of internet users, and still our poverty rates are pretty high. So we are a mix of contemporary and traditional world. The idea is that whatever we may do, I do not think that it can ever be applicable to our whole country. Most important thing for the country is to find affordable healthcare solutions from whichever part of the world we can try to learn. If I look at the key healthcare challenges that we have, then my take would be that one of the most important things we have is the inaccessibility. About 700 million Indians which are in the rural areas they do not have access to the healthcare. Now, of course, recently with the announcement of the Ayushman Bharat and the NHPS schemes, there will be some distance that we will travel to address this issue. But this problem is not going to be as easily solved by such announcements, for the simple reason that we have lack of skilled manpower in the country. Now, the skewed doctor-patient ratio, which is seen as in our country as 1:1700 as compared to 1:1000 in the developed countries, this is again very misleading, because I think for the metro cities, for the bigger cities, this ratio must be again closer to 1:1000, while the ratio in the rural areas and the far off areas will be more than 1:3000, 4000, whatever. We do not have, number one, data to, in fact, do not have mapping of this kind of thing to take it in a very structured way forward. We have vast variations in our literacy, and therefore our approach to reach people in terms of their health awareness, in terms of the strategies which are to be used, will have to be multi-pronged. No one approach can fulfill all the needs. Our system of medical record keeping is still traditional. It is a paper-based system because most people feel it is very reliable. The fear of technology failing is still very high. And on top of that, there is all this, I would say, the Western system of the, I would say, my data being secure or not, or should my healthcare data be available for in the common pool, has been created as a big fear. And without that data, I think we cannot create structured solutions. We do not have at the moment national standards to follow. I mean, the standards are there, a lot of standards are there on the paper in terms of compliance to the EMR and EHR, but then there is a reluctance of the medical and the nursing level people and their attitude for them to change. Then, and the third big challenge is that now, besides the usual problems of the infections, besides the problems like malaria, dengue, and of course tuberculosis taking a huge toll of life in our country, we have a rise in the chronic and the lifestyle-based conditions. And this is now becoming a huge problem, especially in the metro towns. So absence of a system that seeks to manage the chronic conditions is causing a great problem. So with this, what we feel is that help which we can come from developed nations like Sweden will be a great help, and we are looking forward to, I would say, solutions which are disruptive, which can bring about change for the positive for our healthcare.